2 divided doses according to the guideline. So one study from the ICH Kolkata, we compared that single versus divided dose of steroid, and we found that there is no difference between the effectiveness, but there is difference of less HP axis suppression and higher, longer duration of the first relapse in case of single daily dose compared to the divided dose. What the use of antacid and calcium? So the guideline not recommend to use routine use of antacid, but if the child is complaining of gastritis and you feel that child is having clinically symptoms and gastritis, definitely we can use that antacid. And also the recommendation of the calcium, no need to routine, but we need to ensure the child is taking adequate amount of calcium and vitamin D. And if there is less intake or the level is less, then you need to definitely treat that condition. Treatment of the relapse is starting full dose steroid 16 mg per meter square per day for till the remission or at least 2 weeks, and make it sustain remission, make it 4 weeks of alternate steroid. So just few definitions we are discussing here. The remission is defined as urine protein trace on nail for 3 consecutive days. Relapse is defined if it is urine protein more than equal to 3 days, 3 plus positive for 3 consecutive days. And frequent relapse, that has some change here actually. The first 6 months, 2 or more relapse is enough to diagnose, but and subsequently more than equal to 3 relapse or in 6 months or more than equal to 4 relapse in a year. Steroid dependence is the same, remains same, that 2 relapse in consecutive 2 relapse with alternate steroid or after stopping 14 days of steroid. SRNS diagnosis, steroid resistant diagnosis has changed. That is, initially it was a 4-week full dose steroid, but it's become to 6 weeks of. After 6 weeks of steroid, if not respond, then can say it's a steroid resistant nephrotic syndrome. So after the standard treatment, about 30% of child show no relapse, but they will not come back with the relapse symptoms. But about 60% could have a relapse. Like FRNS about 10 to 20%, FRNS like 20 to 30%, and steroid dependent could be 20 to 30%, and 5 to 10% kids not going to relapse. It could be a initial steroid resistant. So I'm just finishing here because it's very briefly presenting here. So key points is that evaluation mainly based on the clinical and basic laboratory findings. Kidney biopsy only indicating a atypical or resistant case of nephrotic syndrome, and managing of nephrotic syndrome based mainly on the steroid and the supportive care I have discussed. And the prognosis, it's found that prolonged initial therapy. Previously it was 4 plus 4 weeks of steroid, but now is 6 plus 6 weeks of steroid gives a better outcome than the previous regimen. Thank you.
Thank you, Dr. Suvankar, for your lucid presentation on a very common topic, that is nephrotic syndrome in children, first episode. Yes, we had different treatment protocols earlier, which has now been standardized by APNEICON recently published in 2025, and definitions also have been changing from earlier to now. Like you said, treatment also has some modifications, and fortunately these guidelines have standardized the management of nephrotic syndrome, and almost all of us have treated these type of patients in our routine practice. Just one comment from you, I would like to, that few patients, particularly in pediatric population, they are given deflazacort. Though I never use this apart from prednisone. So what is your take on deflazacort?
All the guidelines clearly rejecting that hypothesis, and we have never used deflazacort in our practice, and any medicine never used that deflazacort right now. Deflazacort most probably is in DFT, but it's very rare.
A few prescriptions from periphery, I have got that they have administered deflazacort, but we are not practicing this.
Prednisone is widely available and cheap, and all the guidelines recommending that, and all the institutes also use that target.
Sure.
Nice presentation, Dr. Suvankar. One question. Actually, many times we see the patient comes with the relapse, with the septicemia and the volume overload. And how we should proceed for that time for the patient?
So actually, nephrotic usually is not a case of volume overload status. I will say it's intravascular hypovolemia. But when the child present with sepsis, with volume overload, with nephrotic kind of picture, definitely look either AK is hidden or not there actually. The treatment plan will be different actually. Because managing the sepsis, stabilizing the patient, steroid can start after that actually. It's not that starting immediately the steroid. So managing the sepsis, managing the AKI, then you can plan to start the steroid.
The thing is that when we start with the management of the septicemia, the patient becomes very, it means the patient develops excess of the weight. So it's difficult that time. We can use simultaneously the steroid and the antibiotic at that time or not.
So if the child is not received steroid in the past or is the first episode of nephrotic syndrome, I would say we manage the edema by your diuretics and use of albumin rather than starting the steroid. This is the best take on. If the child already received steroid, definitely start the stage 2 steroid. Since after the treating the sepsis is over, sepsis and stress period is over, then you can make the full dose of steroid.
So any question from the
Dr. Suvankar, what is your take on regarding use of 4-trimoxazole prophylaxis with steroid in treatment of nephrotic syndrome? Because few centers have often started this practice also.
Okay, so the main issue is for preventing the PCP pneumonia. Even the rituximab, post-rituximab, it's used actually routinely in some center, but not always. So after, even the SRNS, we are not using any cotrimazole for the preventing. But if vigilance, we have a case too. So I have a case recently managed. A child received, I think from this area only, they reached there. It took a long duration of the cyclophosphamide. And child developed PCP pneumonia. We got the diagnosis also, and we treated his response is very nice. But child was gone through a very, very serious condition, required HFNC and everything, and HFO ventilator. So we never use in our practice as a nephrotic receive the steroid, MMF, tacrolimus, we never use that actually. We are using cotrimazole after rituximab around 3 months as a prophylactic dose.
Any chance of spontaneous remission of these patients? Should we wait for the spontaneous remission and after some time we start the therapy, or just after seeing the first episode in 2-3 days we should start the therapy?
So actually, Dr. Bagga used to say, whatever study you are doing actually, the 30% patient could have a spontaneous remission. Suppose the child already is a known case of nephrotic syndrome, child develops some infection, they relapse. But if you sometimes some patients reach already they will become negative actually. And if it is a first episode of nephrotic syndrome, if you have a fit the criteria, I would say better to treat. If you not treat, child will come with after 1 or 2 weeks the full blown relapse, and it definitely will then treat actually. So either way you have to decide to treat that.
Okay, if there is no question, then we can conclude this session.
So thanks so much.
Thank you, sir. Thank you, all the chairpersons. Please come for the introduction. Moving on next, we have a panel discussion, and the moderator is Dr. Himesh Burman, sir. I request Dr. Himesh Burman to come on dais, and the panelists Dr. Vivek Sharma, Dr. Smita Saha, and Dr. Madhu Sinha Nayak.
So, good afternoon, everyone. Okay. So, good afternoon, everyone. I would like to start with inviting my panelists, Dr. Madhu, Dr. Sharma, and Dr. Saha. Just before starting this, I would like to know my audience. Just by raise of hands, how many of you are pediatricians and pediatrics residents? Okay. And how many are adult nephrology? Okay, great. So let's start. Here in this panel discussion, we were given the topic of difficult to treat nephrotic syndrome, and as per the ISBN guidelines, that defines difficult to treat nephrotic syndrome as failure of sustained remission after 2 steroid-sparing agent. But what we decided is we will not strictly keep ourselves to the standard definition of steroid-sparing nephrotic difficult to treat nephrotic syndrome, but we have molded ourselves more on a perceived difficulty in situations where we perceive that nephrotic syndrome is difficult. So with that, first I'll come to Dr. Madhu. What are the parts of nephrotic syndrome you find most confusing as a case, and confusing, frustrating, and you thought somebody will tell you more about that?
So good afternoon everyone, and first of all, I want to pay my sincere gratitude to our organizing team for giving me this opportunity, and also want to thank Dr. Himesh for being our moderator. So I think most, if not all of the pediatricians sitting in this crowd would agree with me that we all find this nephrotic syndrome management very challenging, because most of these cases are very chronic and relapsing, and also there are very strict protocols, and also the parents and the child, they are very much frustrated with the long course of the disease and the management. So the first pain point I think is the frequent relapsing cases, the steroid dependent ones, the steroid resistant. That is the group I find very confusing, and I find it difficult to manage, and most of the time I'm referring to nephrologist. Other than that, many of the times we are not very sure to use the diuretics, whether to use or not, what doses to be given. Using this albumin infusion, most of the time I'm sending to nephrologists. And apart from that, many of the times children are having some big confusion whether it's a nephrotic or nephritic or overlap between the two. And last but not the least, most of the time I'm not very sure when to refer this child to your patient.
Right. So, in simple words, if I may say, nephrotic syndrome is very messy. Very messy, and that's where the problem starts with. I will come to Dr. Saha. So you have walked in a few medical colleges, and when you are in a medical college level, what are the conditions or circumstances in which nephrotic children get referred to you in medical college? And in medical college, is there any subset that you find difficult to manage?
Yes, sir. Mostly in our centers, when we get a referral of a case of nephrotic syndrome, they are usually having a frequent relapse or steroid-dependent course and need to be started on a steroid-sparing agent. Sometimes they have already been started on a steroid-sparing agent, but they're still having a relapsing course, and we need to decide on a second-line steroid-sparing agent for these children. Often, steroid-sensitive nephrotic syndrome kids with severe resistant edema are also referred who require adequate management of edema. Steroid-resistant cases who require renal biopsy and initiation of calcium inhibitors are referred. And lastly, children who are having overlapping features, maybe gross or microscopic hematuria, low C3, or any systemic manifestations. So these are the cases that are referred. And as per challenges on treating nephrotic syndrome children who are already there in an institute, often resistant edema is a very challenging part. Maintaining compliance of patients who have been started on steroid-sparing agents is also something I find difficult.
Yeah, right. So if I may summarize, means these are some pain points that most of us feel. It keeps on coming. Yes, right. So it never gets. That's the problem. Infections are difficult. Which test to order? That may be a diuretics. Madam was wondering how much do we use albumin when? Sometimes at pediatrician's level, which is nephrotic syndrome, where it's another significant lesion, that becomes difficult to decide and when to refer. So to discuss these points, I'll just start with a case here. Let's say Rahul is a 7-year-old diagnosed with nephrotic syndrome in early December 2021. He has completed 12 weeks of steroid on March 2022. His first relapse was on April 2022. Now he has started with associated pain abdomen, but he doesn't look well, right? And he is in shock. So, Dr. Saha, how would you go about it?
Sir, so this child who is 7 years old had his first episode in December and is now presented with relapse. On the first look, as you have mentioned, the child doesn't look well and is having pain abdomen. So in nephrotic syndrome children, we keep a very high suspicion for infections. And so after taking blood samples, I would like to start the patient on IV antibiotics and start the patient on stress dose steroids because the suspicion for infection is high, and so we keep a low threshold for starting antibiotics initially. Since the patient is in shock and is having pain abdomen, we know that often hypovolemia can also be a cause of pain abdomen in nephrotic syndrome. So we need to assess the volume status of the patient by taking a history of any preceding loss, on clinically examining the child and finding signs of hypovolemia, or taking the IVC status. And if we find that it is hypovolemia, we manage it.
We'll come to the discussion of hypovolemia, but here the thing is that the child doesn't look well, and that is a very soft clue when we think that there is an underlying infection, right? So, like nephrotic syndrome may not give florid signs of infection, and just that the child is not well should raise suspicion that there is an underlying infection, and we should look for it out here because there is a symptom localizing to the abdomen that there is possibly that could be the source, either a cellulitis or a spontaneous bacterial peritonitis. Right? We'll come to the discussion on how do you define complicated relapse?
So, sir, a nephrotic syndrome child like this who is presenting with infection, and later if we find that yes, indeed it was a severe infection which can be spontaneous bacterial peritonitis, cellulitis or meningitis, then that is regarded as complicated relapse. Then a patient of nephrotic syndrome with hypovolemia due to reduced intravascular volume who is requiring hospital management for treatment of hypovolemia is also considered as a complicated relapse. Thirdly, we know that nephrotic syndrome is a prosthrombotic state, and especially in patients who are already dehydrated, they can present with thrombosis. So any patient presenting with a thrombotic complication is also defined as a complicated relapse.
So the thing is that this is a relatively newer definition. Earlier guidelines didn't have that. So we need to look at whether nephrotic syndrome has complications or not, and then in principle our urgency to maintain them relapse-free is more, because if there is more than one such relapses, we'll discuss that again, then the chances are that they will again have these relapses if we want to keep them not relapsing. Right, so we think of complications, think of antibiotics, volume assessment, shock, and stress dose of steroid. That is one thing that is important. So when you are suspecting infection, we will not start with full dose of steroid, but always remember these children should be on stress dose of steroids. Right, so let's take the case of Rahul forward. So Rahul's first relapse was in April 22, completed steroid for relapse by May, relapsed again in early June. And Rahul has now severe sphenoid features. He needed hospitalization again for spontaneous bacterial peritonitis. Dr. Madhu, would you be comfortable keeping this case with you? And would you consider steroid sparing agent at this point?
This is a case of frequently relapsing nephrotic syndrome along with complication, and also the child is having severe Cushingoid feature. That means the child is developing steroid toxicity. So looking at all these features, I would feel better referring the child to a pediatric nephrologist. And definitely, since the child is developing this steroid toxicity and is a complicated one with frequent relapse, steroid sparing agents must be given, and they will be decided by the pediatric nephrologist.
So Dr. Saha, you take on this case? Now?
So, ma'am, as now already discussed, since the child has had 2 relapses within 6 months of initiation of the first episode, we label the child as a frequently relapsing nephrotic syndrome. And he also had 2 complicated relapse. So more than 1 complicated relapse along with features of steroid toxicity, definitely we need to start the child on a steroid sparing agent. And we can discuss on what type of steroid sparing agent the child needs to be initiated on.
Thank you. Dr. Madhu, again coming back to you, what are the other scenarios in which you would diagnose frequent relapse? Here, there were 2 relapses in first 6 months. And how do you diagnose steroid dependence?
So this was the first example where there is frequent relapse. If there are 2 episodes in the initial 2 months after we start the steroid therapy, or if there are 3 or more relapses in any 6 month duration, or 4 or more relapses in any 12 months duration. But we talk about the steroid dependence, then if there are 2 consecutive episodes, once we switch to the alternative therapy, or after stopping this steroid, if there is a remission of these features within 2 weeks, that comes to steroid dependence.
So it's on paper it looks very simple. If you can make this out and you can classify them, but in practice when these patients come and it's difficult to actually classify. So the trick is that we should start counting the relapses from now onwards and go backwards and see that whether they are qualifying into one of these points. So just try to chart down that when was this relapse now, when was the earlier relapse, when was the relapse before that. Go at least 12 months in behind in time and see how many relapses have happened. So that may help. Dr. Vivek, in this child, so Dr. Saha and Dr. Madhu think that steroid sparing agent is needed. So what steroid sparing agent you would choose for Rahul and why?
So here we have a case of frequently relapsing nephrotic syndrome who shows evidence of steroid toxicity as well. Steroid toxicity does not mean only Cushing's phases. We need to look for other features also like obesity, short stature, complications in the eye, posterior subscapular cataract, and bony changes, osteoporosis can be there after starting steroid. So if the child meets this criteria, he has steroid toxicity. I hope this child also had steroid toxicity, as well as he had complicated relapses. So we'll start steroid sparing agent. Either we can use mycophenolate, which would be high dose mycophenolate, around 1000 to 1200 milligram per meter square, or we can use cyclophosphamide. Now out of these 2, which to prefer? Then we look at the age of the child. Younger child normally MMF we prefer because we cannot use cyclophosphamide in less than 5 to 7 years old. This child is I think 7 years old, so we can safely use cyclophosphamide here. And one more thing I would like to reiterate here is that parents should also be taken into confidence because we need to explain the pros and cons of the medicines. They have side effects also. So we need to tell them what will be the course of the treatment and what side effects they can get. And probably here we will use cyclophosphamide as the child is 7-year-old and it is a shorter duration also, and we have seen good response to cyclophosphamide. So my preference will be cyclophosphamide.
So we can either choose based on our personal preference, either mycophenolate and then 1000 to 1200 milligram or cyclophosphamide. Yes. So either one we can choose. But again, as Vivek has pointed out, we have decided to use cyclophosphamide in this case because if we keep cyclophosphamide for later and then this child becomes again in adolescence, that will be a more risky period to start. Yeah, it's like this, and this is a one-time bullet, so we decided to fire the bullet now rather than keeping it for later.
Parental counseling is very important.
Yes, counseling, we cannot stress it enough. It's very, very important that we need to discuss all that. Right, so now in this relapse, we have discussed about steroid-sparing agent, but the child has not gone into remission yet. So we will only consider steroid-sparing agent once it goes into remission. Right? So Rahul has now completed 3 weeks of steroids, and he has still not attained remission yet. He is grossly edematous. At 3 weeks also, his creatinine is 0.8 milligram per deciliter, and the treating doctor has decided to add enalapril because he thought some hypertension is there. So for dual benefit of treating the hypertension and nephroprotection, decided to add enalapril. So Dr. Madhu, do you use enalapril for nephroprotection?
Here we can see an example where the child is not going into remission and the proteinuria is continuing. So if it is going on and on, it will further damage the kidneys. So just to say that we are adding enalapril for nephroprotection, and what that does, it actually reduces the intraglomerular pressure by dilating the efferent arterioles. So that resets the filtering mechanism and reduces the proteinuria, and that helps in a way so we can continue it for a very long time till the proteinuria ceases.
So Matthew has pointed out the use of enalapril and how it works. But again, we need to look at the context of it, right? So Dr. Saha, what are the pointers? When do you decide that you use enalapril and when not?
So for steroid-sensitive nephrotic syndrome cases, we usually do not start them on enalapril. Rather, patients who are steroid-resistant and have been having proteinuria for a long time, we do not expect them to go into remission very soon. We can add enalapril to them, but we need to keep in mind that it is a nephrotoxic drug. So we need to have a baseline creatinine of this patient. We need to check the potassium too, and we also need to check the volume status of the patient. So if the patient is already dehydrated, we will prefer not to initiate enalapril at that time. The index patient we are discussing had a creatinine of 0.8, which is slightly towards the higher side for a 7-year-old boy. So again, probably we will wait for some time before starting enalapril. Moreover, if we are starting enalapril on a child, we need to keep them on close monitoring, and they need to come with their creatinine and potassium reports at regular interval. And at any point, if we see that the baseline creatinine has increased by more than 30%, we need to keep it at hold for at least few days. Also, if the child has an episode of vomiting, few episodes of loose stools and is dehydrated, we need to keep it at hold. So we need to keep in mind these do's and don'ts before initiating any angiotensin converting enzyme inhibitors, and even when we have initiated them.
So drugs, AC inhibitors and ARBs, though what sticks to our head is its nephroprotection and anti-proteinuric effect. But remember that it is only required in chronic, non-remediable proteinuria kind of thing. Whereas in steroid sensitive, this child is not in remission at 3 weeks. But if it is steroid sensitive, it will go into remission in next 1 week or so. So unless we diagnose steroid resistance, we should probably refrain, because the benefit will be much lesser than the risk we are putting in this case. So that is what happened, and Rahul, who was probably hypovolemic intravascularly because of the edema, the infection, and creatinine was already on the higher side. The creatinine jumped further to around 1.8, and when for hypertension enalapril was replaced with amlodipine, and the creatinine came back to baseline. Once then he eventually attained remission, and he received cyclophosphamide for 12 weeks along with tapering steroids. Dr. Vivek, would you share some practice points for while using cyclophosphamide?
Yes, sure.
And how do you monitor the child?
Cyclophosphamide, I think the most common drug used as steroid-sparing agent. We use orally in a dose of 2 to 2.5 milligram per kg per day, single morning dose. And one thing is important, we always start cyclophosphamide in remission. Whenever the child goes into remission, we change the prednisolone to 1 milligram per kg alternate day, simultaneously we start cyclophosphamide. And since it has got significant adverse events, adverse side effects also, so only single course is advised. It cannot be repeated, and the duration is 8 to 12 weeks. If we use 2 milligram per kg, we can go up to 12 weeks. If we are using 2.5 to 3 milligram per kg, we can restrict to 8
It's
weeks.
important that we keep the cumulative dose as
Cumulative dose should be not more than 168 milligram per kg, and we should always keep a tab of the side effects.
And it's a single-use bullet. So when we are deciding to use cyclophosphamide, always make sure that the child has not been prescribed it by someone else.
While earlier, yes. So, and one more thing, the age group. Age should be more than 5 to 7 years, not in younger child. Also not in pubertal or post-pubertal age. And the side effects. What are the side effects? One is alopecia. I think it will come back once the drug stops. Hemorrhagic cystitis. Hemorrhagic cystitis you can manage by giving plenty of fluids and increase.
Oral cyclophosphamide, it's usually not
yes.
that much, but we need to keep about the counts more important.
Yes.
So it's
So
important.
every 2 weeks we should do a complete blood count, and whenever we find that the total lymphocyte count less than 4,000, we should stop temporarily. We can restart again if it goes beyond 4. So we have to maintain TLC more than 4,000.
So, Dr. Saha, in which cases would you prefer mycophenolate? And briefly about it, very briefly.
So between cyclophosphamide and mycophenolate, as we have already discussed, so we cannot use cyclophosphamide in younger children and in adolescent and post-adolescent age group. So we will prefer mycophenolate in these patients. If we have a confusion between levodopa and mycophenolate, studies have seen that mycophenolate is more effective in younger age group and also in steroid-dependent cases compared to levodopa. So in these cases, we would prefer mycophenolate. Toxicities of mycophenolate, sir. Usually they have drug-related symptoms of GI intolerance in the form of pain, abdomen, diarrhea. So the gastric intolerance is the major side effect of mycophenolate mofetil. So basically the active component of mycophenolate is mycophenolic acid. This is a gastric irritant. So that is the reason why the symptoms arise. So
I think we'll leave the discussion here because there is another here on that. Let's move on to the next slide. So now what happened? Rahul, he relapsed again on 0.6 mg per kg because of a viral infection. And he develops generalized edema, tachycardia, and whole periphery, needed hospitalization again. So, Dr. Vivek, is there any strategy to prevent infection-induced relapse?
Yes, this child was probably on alternate days, 0.6 milligram per kg. So, whenever there is infection, whether in the form of URT also, this can lead to relapse. So, what we need to do is, like in this child, we'll make the alternate day steroid daily. That's in the same dose. So 0.6 milligram per kg will give it for 5 to 7 days at the onset of the infection. This would definitely prevent the relapse in this case.
Right.
Secondly, we can, in order to prevent the infection, we can obviously vaccinate the child, especially with pneumococcal and flu vaccines. And as in the previous talk, also sir was saying prophylactics, etc. But not in this case, but...
So here the point we are wanting to make is that if the child is on alternate day steroid, the guidelines recommend that adding 3 additional doses of the steroid. That means we make it daily. The child was anyway on alternate day steroid, so that means only 3 additional doses in a week. So, and that may be able to prevent, though evidence is not very strong, but that is what is currently recommended. Severity of edema, we have to decide whether it's a mild, moderate, severe. That's Dr. Madhu. In a child who is edematous, how do you assess volume? Because we thought about that while deciding.
Actually, the children are bloated, so many times it's very difficult to decide whether the child is hypervolemic or hypovolemic. So we look at certain clinical signs and certain investigations made accordingly. Bedside, like we look for this edema, especially it is in setting of severe diarrhea and vomiting. Then it is pointed towards the hypovolemia. We can look for any abdominal pain, dizziness, lethargy. They are also pointing towards the hypovolemia, tachycardia, parallel. The CFT is more than 2 seconds. there is child is having hypotension, features of shock. All these are pointers towards hypovolemia. And apart from that, we can do certain investigations like APNEICON is less than 0.5, potassium index more than 0.6. If hematocrit is high, we can do ultrasound to look the IBC for its diameter and collapsibility.
We have this clinical assessment, some urinary biochemistry and some imaging. So remember that when we start on furosemide, then the urinary biochemistry will no longer be useful. And we mostly rely on the clinical parameter, and we can always take care of focus for that. Dr. Vivek, when do we use albumin in management?
Yes, in nephrotic syndrome, the child presents with edema. First of all, we see whether the volume status. And the child is hypovolemic. What we need to do is we can give crystalloids, normal saline bolus, 1 or 2 boluses we can give. If child is still not passing urine, we can use albumin. 20% albumin, 0.5 to 1 gram per kg, we give over 3 to 4 hours and see. Because this will bring the extravascular fluid to the intravascular compartment and dialysis will start. Second thing, if the child is shocked also, after boluses or crystalloid, we can give bolus of chlorides also, that is the form of albumin. Then comes the moderate edema. Moderate edema is usually managed with diuretics. But even if after giving diuretic like furosemide, if the child is not passing urine, this is a state of diuretic resistance. What exactly is diuretic resistance? Furosemide, this requires albumin. They both combine and then it is transferred to the ascending loop of Henle where the furosemide acts. But the child is already hypoalbuminemic. Albumin is not there to combine with furosemide. So this will not be delivered to the ascending loop of Henle where it is going to act. So what we do, we give albumin infusion over 4 hours and followed by furosemide injection. So that it leads, combines with albumin and acts at the point.
Albumin, we are not using a particular cutoff for albumin, serum albumin level, but we are using it to improve the pharmacokinetics of diuretics. So basically, diuretic resistance is an indication, not specific albumin level. And in hypovolemia, we are using it as a colloid volume.
Yes.
Okay. So quickly, Dr. Saha, on sequential nephron blockade, how do you use?
Sir, so initially for any edema, we start the patient on the loop diuretics, that is furosemide. We know that loop diuretics are blocking the sodium potassium dichloride transporter at the level of descending loop of Henle. However, because of this blockade, there is increased delivery of this sodium to the distal tubules. So there is compensatory increased activity at that level, and sometimes there is increased reabsorption of sodium along with water. So if we find that after starting the child on the loop diuretic, the edema is not getting corrected or the urine output is not as we are expecting, then we can think of adding a thiazide diuretic along with the loop diuretic. So this is a sequential blockage. It will block both the distal convoluted tubule sodium chloride transporter and also the thick ascending loop of Henle. As a result of this distal compensated reabsorption that was occurring, that will stop and they have a synergistic effect.
Okay, thanks. This I think Dr. Shubhakar has already covered, but quickly, in this case, do you need biopsy?
Sir, so now, as you said that the child has already received cyclophosphamide and mycophenolate over the years and has not attained remission, he has attained, as per the definition of ISP, a difficult to treat nephrotic syndrome. So if we want to start him on calcineurin inhibitors, yes, we would like to proceed with the renal biopsy baseline before starting him on.
So there is again the guideline on whether you do a pre-CNI biopsy or not is also evolving. So for pediatricians, it's not a call for you. It's better you send it to somebody who is seeing these children and let them decide whether a biopsy is needed or not. I'm not going to the standard biopsy indications. This is probably the last question we will go take for this one. So now this child is steroid is difficult to treat.
It satisfies all the
So yeah, let me stop it here because in interest of time, and I don't know if your organizers allow 1 or 2 questions. Okay, now we are stopping it here.
Thank you. Thank you.
Okay. Thank you so much.
Thank you.
Thank you, sir. Thank you, all the chairpersons. We'll go moving on next. We have talk by Dr. Himesh Burman again. And for chairing that session, I will request Professor Dr. Vinod Kumar Singh, ex-head Nephrology Department, PMCH. Vinod, sir. Dr. Shravan Kumar, a famous neonatologist from the Patna, you all know about him. And Dr. Akhilesh, sir, Professor of Pediatrics, Nanda Medical Hospital. Sir, please come on the dais. I welcome you all. And speaker, Dr. Himesh Burman.
Ready?
So for the next talk, I am actually filling the shoes of Dr. Subal Pradhan, who was supposed to talk on steroid-resistant nephrotic syndrome, but he could not make it because of some urgent family commitments. And in the pediatric nephrology community in his zone would know that filling up Dr. Subal Pradhan's shoes are not very easy. It's a
Good morning to all. The next topic of presentation is the steroid-resistant nephrotic syndrome. I think the most complicated one. And the presenter is again Dr. Himesh Burman, sir. He is the professor and head at the Ceylon. And he has got interest in the glomerular disease, AKI, and medical education point of quality care.
Thank you, sir.
Yes, thank you for the honor, and we pediatricians are really very much obliged to your faculty that you are repeatedly doing every topic about nephrotic syndrome, and we are happy that we are learning a lot. Thank you.
Thank you so much, sir. So again, as I have said, these are slides by Dr. Subal, and I am just filling his shoes. So nephrotic syndrome in one form or the other has been known from long time, and from era of Hippocrates there are some signs on kidney diseases were explained, and the diagnosis evolved until Richard Wright and colleagues in 1858 initially showed proteinuria as a part of kidney disease, and then late 19th century nephrotic syndrome was recognized as a distinct kidney disease. The first randomized controlled trial in pediatric nephrology was done by the ISKDC group in 1966, and the series of publications that actually set the standard for management of nephrotic syndrome, and that has been the backbone of all other studies that have followed after that. So we all know that nephrotic syndromes we can classify into steroid sensitive. 75 to 90% are steroid sensitive, whereas steroid resistance becomes 10 to 25%. When there is steroid resistance, then we start with the agent, and usually the CNI is the drug of choice. And after that, if there is at least partial remission, we want to achieve by around 6 months. But if that is not achieved, we would call it a steroid CNI resistant nephrotic syndrome. And if after adding another agent, the lack of complete remission following treatment with 2 different immunosuppressant drugs for 12 months would get it classified as multi-drug resistant steroid resistant nephrotic syndrome. This is how the definition of steroid resistant nephrotic syndrome has evolved. So by the ISPDC group defined it on 4 weeks. So how was the 4 weeks? 4 weeks decided it was very empirical. The group decided that let's treat like that before that we knew that steroids work for nephrotic syndrome, but there was no regime. How do we treat that? So they just started with 4+4 and showed that in 4 weeks 94% of patients would go into remission. And by increasing it further to 6 weeks, additional 3% would only go to remission, and that's how the definition of 4 weeks was kept. And then later on, this evolved. It was evolved that maybe we should give more chance and see that if we can keep those 3% also included, and the definition was changed. Even the ISPN guideline initially showed guidelines. There is nothing needs to be done. If we don't get remission, we just straight away define as steroid resistant nephrotic syndrome. But again, there are some guidelines that talks about giving 3 additional doses of methylprednisolone or with or without RAS blocking. So these are few things that are coming up. But as per the Indian Society of Pediatric Nephrology guideline, if no remission at 4 weeks, you think that this child is probably steroid resistant, you continue for another 2 weeks of full dose of steroid, and at 6 weeks, if there is no remission, you diagnose it. For biopsy and other things, you start counseling at 4 weeks itself, because by the time when it's 6 weeks, if you start counseling, it will take additional 2 weeks more. So start counseling at 4 weeks and confirm the diagnosis at 6 weeks. Yeah. And for next important thing is earlier when there is steroid resistance, you need to think about a biopsy and you need to do a biopsy. But there are some subset of indications where you need to think about genetic testing, and these include if there is a family history of or if there is syndromic cases with SRNS. In some of these conditions, you need to think about asking for genetic testing. So, monogenic SRNS, you may have syndromes. It's difficult to remember all those syndromes, but if you have any extrarenal stigmata of a congenital condition, in these conditions you should think about the syndromic SRNS. We can, in this situation, we can think of genetics. And congenital nephrotic syndromes, we know that 78% will have NPHS mutations, but there are other mutations that can be present, and some non-syndromic SRNS also may have some some of the genetic mutations. So the role of genetics in evaluation of a patient with SRNS is evolving, and that is primarily because we can distinguish which cases need immunosuppression, and we know that genetic SRNS with genetic basis do not do well with immunosuppression, and they can be spared the side effect of immunosuppression. So indications of genetic testing, ISPN talks about these initial SRNS, familial SRNS, non-response to CNI and prior to transplantation, and KDIGO-25 talks about steroid-resistant nephrotic syndrome, congenital and infantile nephrotic syndrome, NSC syndromic features, and family history of SRNS or FSH. So there is a significant role of asking for genetics in cases with steroid-resistant nephrotic syndrome. So diagnostic utility of performing kidney biopsies in SRNS. So in ISPN 2021, all patients with SRNS should be asked for this one, except when we can, in conditions where we are asking for genetics first. Okay, so but KDIGO-25 recommends biopsy for all cases of SRNS. So you can do biopsy plus minus genetics in these cases. So limitation is most genetic causes of SRNS have histologic features that are not distinguishing from non-genetic disease. So even if you do a biopsy, you cannot make out this is a familial or non-familial. So you can probably in these select subgroup ask for a genetic test, and that can impact the management of these cases. Right. So evolution of therapy. There are a lot of drugs that have come, starting from cortisone in 1950s, and we have newer agents coming now. So, but the most of the we have evidence still rituximab. We have good evidence in pediatrics, and there are only case reports or rescue reports or therapies in cases of other newer anti-CD20 and other drugs, but those are mostly extrapolated from the experiences in adults. So this is the current status. So current management of pediatric SRNS, we give CNI for 6 months in treatment of choice. Then if there is CNI resistance, then alternate therapy, rituximab, which can induce remission in additional 30% of these cases. And then if it becomes multi-drug resistance, then more intensive immunosuppression can be used. And these preferably should be enrolled into a clinical trial in such situations. So they may include multi-drug therapy, combined rituximab and daratumumab, IV, and rituximab. So these are options, but none of them has any robust evidence in pediatric age group, and there are small reports only. So treatment of monogenic SRNS, less likely to respond to immunosuppressant. So if we still need to give 6 months treatment of CNI, because there is a small proportion that may respond to it, like around 6.3%, and partial remission can be attained in 21.3%. And the mechanism is not by immunosuppression. There are some other mechanisms by which stabilization of photocyte happens, and this can happen, and the RAS inhibition should be mandatory in all these cases. So, this highlights the potential therapeutic approach of SRNS. So, IPNA recommendations, if non-remission after full dose of prednisolone, then we, for 4 weeks, then we go to 1 to 2 weeks of confirmation period. If this happens, then if we are suspecting monogenic SRNS, we confirm by genetics, we continue RAS inhibition, and as I have said, immunosuppression, and we can decide not to do with immunosuppression, use calcium inhibitors. Give for 6 months. If CNI resistance is there, then we can use other drugs. Rituximab would be the next drug, and if rituximab fails, then it goes into a more intense other multi-drug therapy can be started. So to conclude, significant advances in understanding of disease pathology and optimizing outcome has happened, but still the evidence for newer drugs in pediatric patients is very limited. Autoantibodies are involved in some of the non-genetic cases of SRNS. That is the basis of intensifying immunosuppression in these cases where they are not responding. And this is also the basis of not going into more intensive immunization in more intensive immunosuppression in SRNS cases. Current classification is based on response to immunosuppression and presence of genetic variant, and to identify the genetic cause is important to avoid ineffective therapy and to avoid the side effects of immunosuppression in these cases. And in future, pragmatic classification should be considered to enable personalized and precision medicine. Thank you.
Thank you for such a nice presentation. And one question I will like to know that as a pediatrician, in simple word, say that 4 weeks or 6 weeks, how long we should treat, and then we can say that steroid resistant. And what is the when you will recommend for the genetic testing like that for that?
Sir, to take your first question first, when it was on when to decide. So we will follow the ISTN guideline, and that is at 6 weeks. But we should start thinking about that this child is probably becoming resistant at 4 weeks, and we should start talking to the family in that terms so that we can quickly do a biopsy or genetics, whatever is required at 6 weeks. So definition is at 6 weeks, but we should start thinking in those lines for 4 weeks onwards and prepare the parents. That's point number one. And next question was genetic testing. So genetic testing, in congenital and infantile nephrotic syndrome, where we need to think about genetics. Then we should think about familial nephrotic syndrome, and in cases of syndromic nephrotic syndrome. So these 3 groups we can talk about, where we should talk about genetics.
Where we should start? When should send for exome sequencing or like that?
Sir, we can in infantile nephrotic syndrome we can send it at beginning itself, because if we find, and because these reports also take more time to come, so in that we need not wait till the definition of steroid resistance is achieved. But if we think that there could be a genetic basis, we can send the whole exome sequencing and wait for it and take that in your clinical decision making algorithm.
Thank you.
And primary nephrotic syndrome. Primary steroid resistant nephrotic.
Yes, primary steroid resistant.
So not for like a secondary, like initial was steroid sensitive, we are 100% we know that it was steroid sensitive, and then it becomes a steroid resistant, then chances of finding a genetic is low. So primary steroid resistance, in like right from the day one, it never responded to steroid.
Yes.
Thank you, Dr. Ramesh. Our next speaker is Dr. Devlani Gupta. She is Assistant Professor Division of Pediatric Nephrology from Kolkata. Her interest is in cystic kidney, lupus, AKI, etc. And she will talk on steroid-sparing agents in nephrotic syndrome in children and overweight. Dr. Devlani.
Thank you, sir, for the kind introduction. I have been asked to give a brief overview about the various steroid-sparing agents in steroid-sensitive nephrotic syndrome, and my job has already become an easy one because much of it has already been discussed in the panel discussion previously. I think my slides are taking some time to load. So we know that in steroid-sensitive nephrotic syndrome, nearly 50 to 60% of the children end up being frequently relapsing or steroid dependent, and they are predisposed to development of steroid toxicity, and hence it is very important that we start them on an agent which will help to decrease the dose of steroid and at the same time maintaining remission. So here comes the roles of the various steroid-sparing agents. So let's start off with a case scenario. A 5-year-old male child who was diagnosed with first episode of nephrotic syndrome in October 2023 was appropriately treated. Later on had 2 relapses in the following 6 months. So the child was started on long-term alternate prednisolone, but despite that the child continued to be steroid dependent with a steroid threshold of 0.75 mg per kg. But luckily the child did not develop any features of steroid toxicity. So what should be done next? So as per the ISPN guideline, in these situations where the child is having an FRNS SDMS scores with a low steroid threshold without any significant steroid toxicity, we should first try to use levomizole or mycophenolate mofetil. So let's concentrate on levomizole for some time. So how exactly does it act? It's actually an anti-helminthic which was previously used, and it has an immunomodulatory action. It tends to decrease the Th2 cells, it tends to upregulate the Th1 cells and also increase the CD4 plus cells, thereby helping to decrease the podocyte food process effacement, thereby decreasing the proteinuria, and it also directly acts on the podocytes by increasing the glucocorticoid receptors, thereby increasing the sensitivity towards steroids. So, as a steroid-sparing agent, it was found to be pretty effective. It resulted in 35% reduction in relapse risk in comparison to prednisolone at 6 to 12 months, and it is better, more efficacious in frequently relapsing than steroid-dependent nephrotic syndrome. And there was an RCT which was done by AIIMS New Delhi, where it was shown that MMF when used at a dose of 750 to 1000 mg per meter square per day is not superior to levomizole in reducing the frequency of relapses or the likelihood of sustained remission in pediatric patients who are having FRNS SDMS. In comparison to cyclophosphamide, also some small RCTs are there which have shown a similar relapse risk. So it has a more or less a good efficacy, and that's why, and the side effect profile is also not that bad, and that's why probably it is preferable as the first line of steroid-sparing agent in children with FRNS SDMS. So usually it is used at a dose of 2 to 2.5 mg per kg on alternate days for 2 to 3 years. And there have been some studies that have tried to explore whether daily dosing will be better than alternate day dosing. There are some observational studies which have shown reduction in relapse rate, and there was this RCT which was done from our center that showed that in comparison to alternative dosing, daily dosing resulted in similar sustained remission rates at 12 months. However, with the daily dosing, there was lower relapse rate, and the cumulative steroid dosage was also less, with similar side effect incidence in the both groups. Levomizole is known for causing some adverse drug reactions like leukopenia, transaminitis, and some vasculitic skin rashes. So it is very important that we monitor for these rashes at every visit, and also we monitor the complete blood counts every 2 to 3 monthly, the SGOT, SGPT every 4 to 6 monthly. Usually even if they get deranged, they normalize when we go for a dose reduction, and definitely they normalize if we discontinue the treatment for a bit. ANCA-positive vasculitis has been found to occur in 2% of the cases, so it is very important to check for the ANCA titers at baseline and thereafter 6 monthly, and if ANCA titers are found to be positive, then we should stop levomizole. So in the index trial, the parents opted for levomizole. Levomizole MMF at low dose have similar efficacy, and at the same time levomizole is cheaper than MMF, so it is understandable why the parents opted for levomizole. Now coming back to this child, we started the child on levomizole, but despite that the child continued to have a steroid dependent course and eventually started developing features of steroid toxicity. So now what will you do? As per the ICM guideline, it says that if a child has started developing features of significant steroid toxicity with a high steroid threshold, then you should try to use mycophenolate mofetil or cyclophosphamide. So mycophenolate mofetil is actually it's an inosine monophosphate dehydrogenase inhibitor, which tends to decrease nucleic acid synthesis, thereby causing inhibition of T and B cell proliferation. And this is how it is effective in children with steroid-sensitive nephrotic syndrome. It has a good steroid-sparing effect, and it has been found that in comparison to prednisolone, it tends to cause 50% relapse risk reduction, although studies are mostly observational. Usually whatever studies are there, RCTs, observational, whatever, mostly they have used a dosing of 1000 to 1200 mg per meter square per day in 2 to 3 divided doses, and that's why APNEICON also recommends using this dosage. And especially at higher dosage, the efficacy is better when we are able to achieve an area under the curve concentration of the serum level more than 50 mg hours per liter, when it becomes almost as efficacious as the CMS. ISBN, however, says that you start at a low dose, because of the study that I just showed you, where MMF at a dose of 750,000 mg per meter square per day was found to be more or less having similar efficacy to levomizole. So you start off with a lower dose, and in case the patient doesn't respond, then you hike it up, and you can go up to a dose of 1200 mg per meter square per day. And even with that, if you are not able to achieve a proper response, you can even go for therapeutic drug level monitoring, targeting an AUC more than 45 to 50. Duration, there is no such study that is actually trying to assess what should be the ideal duration. ISBN 2021 recommends use it for 2 to 3 years, and IPNA says that you use it at least till the child is relapsed from 1 year. Mycophenolate sodium is a prodrug of MMF, and it has been found to have a better GI tolerance because GI intolerance may be a problem with MMF. So you can use NPS also instead of MMF. There are no head-on trials which have tried to assess the efficacy between the two. And when you are dosing it, remember that 500 mg of MMF is equal to 360 mg of NPS. So as I said, MMF causes GI intolerance, and it is usually dose dependent. You should look for this at every visit, and you may switch to NPS if these are happening. It can cause leukopenia, transaminitis, viral wars. It is important to monitor for these complications every 3 to 6 months. If they happen, decrease the dose, discontinue treatment. Mostly these are mild, and they will revert back to normal after you discontinue the treatment, and even if you restart the drug later on. And it is notorious for causing teratogenicity. So in sexually active adolescent females, it is better that you advise contraception if the patient is on MMF. Now what about cyclophosphamide? Because it is also another option that you have in children who are having significant steroid toxicity and SCNS scores. So cyclophosphamide is an alkylating agent, causes DNA alkylation, which inhibits B cell function. It also has a significant steroid-sparing action. It reduces relapse risk, 53% risk reduction at 6 to 12 months, and 79% reduction at 12 to 24 months. There are no RCTs that have compared MMF with cyclophosphamide. There was a study that was done by Dr. Dhuria, where they have tried to assess whether we are able to withdraw steroids, maintaining the children in remission for at least 6 months. So with this primary objective, it was found that cyclo and MMF is similar. However, MMF was found to be having less number of relapses, especially in children less than 5 years of age. And this, in fact, has been reflected earlier also, that cyclophosphamide, there was this large meta-analysis that was done with cyclophosphamide or chloroglucin in children with FRNS, and it was found that cyclophosphamide acts better in children who are more than 5 to 7 years of age and acts better in FRNS than in SCNS. And another important thing about cyclophosphamide is that it tends to have a long-lasting action. So even after you have discontinued the drug, it will tend to cause sustained remission even for years later. So it is given usually at a single course, as already said in the previous panel discussion, 2 to 2.5 mg per kg daily for 8 to 12 weeks, do not exceed cumulative dose of 168 mg per kg, and since it causes leukopenia, it's better to give prednisolone along with it, usually at a dose of 1 mg per kg every alternate day, and then you taper it over in the next 1 to 2 months. And if there are compliance issues, you can give monthly IV 500 mg per meter square per dose cyclopulses for 6 months, which has been found to have similar efficacy. I think this has already been discussed before, so I will not go into all these. It causes neutropenia, leukopenia, thrombocytopenia, you need to monitor. It can cause gonadal toxicity, that's why you should avoid it in peri-pubertal and pubertal boys, and please keep the cumulative dose below 168 mg per kg. So because of these concerns of gonadal toxicity and malignancy, therapy of cyclophosphamide is usually administered after your levomizole and MMF has failed, and you should limit it to 1 12-week course. And occasionally, if the child is more than 7 years of age, having significant steroid toxicity or complicated relapses, you can use it as a first-line steroid spare. So in this index child that I was talking about, MMF probably will be better than cyclo because the child's age is 5 years. However, the decision making has to be done by parents after telling them about the side effects and everything. Some parents may still choose cyclophosphamide because it is way cheaper than MMF, but also you have to take into account that for cyclo, the CBC also needs to be done every 2 weeks, and the parents need to come to you for follow-up. So now let's come to our second case scenario, a 3-year-old female who had first episode of nephrotic syndrome at 1.5 years of age, was steroid sensitive but started having an SCNS course with significant steroid toxicity, failed levomizole, failed MMF. So what should you do in this child? So what are the options that you have? You can use either cyclophosphamide or CNI or rituximab. Now let's talk about CNI a bit. It again has a very significant steroid sparing action, and it has been found that it is better than MMF in reducing the relapse rates and also maintaining sustained remission. And versus cyclophosphamide, it was found that the efficacy is similar as long as you continue CNI. But after you stop CNI, the relapse rates again start increasing in CNI than in the cyclophosphamide group. So that's why, because CNI is more efficacious than MMF, and even in children who have failed cyclophosphamide, if you give CNI, you may be able to decrease the relapse rate in 60 to 90% of the cases. That's why it is preferred in difficult to treat nephrotic syndrome. And for children who are less than 5 years of age with significant steroid toxicity or complicated relapses, you can even use it before MMF because it is more efficacious than MMF, and even before cyclophosphamide because it works better than cyclophosphamide in children less than 5 years of age. So in this case scenario, 3-year-old child with SCNS, probably CNI will be the better choice. So what of time, I don't think I am going to CNS mechanism. Dosing is 4 to 6 mg per kg per day of cyclosporin with trough level of 80 to 120. And for TAC it is 0.1 to 0.2 mg per kg per day with trough level of 4 to 8. Once the condition is controlled, the child is in remission, you can even target lower doses to target the trough level in the lower range of the recommended. And it has to be given for at least 1 year, maximum 2 to 3 years. If beyond that, if you want to continue CNI, better to go for a kidney biopsy or to see whether there was CNI toxicity, or better maybe you can switch to Ritux. So there are a whole lot of adverse effects: nephrotoxicity, hepatotoxicity, hyperkalemia for both. And CSA is more notorious than TAC in causing your cosmetic side effects, hypertension, dyslipidemia. TAC causes mode of neurotoxicity, diabetes mellitus, diarrhea, etc. So it is important to monitor for these side effects. And then a little bit about rituximab. Rituximab is another agent that we have in our armamentarium, which mainly acts by, it's an anti-CD20 monoclonal antibody that decreases B cell activation and B cell dependent T cell activation by helping to cause remission, decrease relapse rates, and also it has a direct action on the podocytes. In comparison to the other steroid-sparing agents, it is much more efficacious than cyclophosphamide, CNI, or even CNI plus PrEP. You should give it 2 doses, 375 mg per meter square per dose 1 week apart, which is better than giving 1 dose. And with the target to deplete the CD19 positive B cells to less than 1% or less than 5 per microliter. But suppose if you are not able to achieve this target with 2 doses, you can give additional 1 to 2 doses. B cells usually repopulate in 6 to 9 months time, so you may have to repeat the Ritux dose to maintain the child in remission. Problem with Redux is that it can cause lot of side effects. It can cause exacerbation of chronic viral infections, acute infections, notorious for causing infusion reactions like anaphylaxis, neutropenia, and another thing is persistent hypogammaglobulinemia, which is specifically problematic in children who are younger than 5 years. That's why its use is recommended only in difficult to treat nephrotic syndrome, in case of CNI dependence, where you plan to prolong the CNI therapy, and definitely you should not try to use it in children less than 5 or 6 years of age. So monitoring, you need to monitor pre-therapy, the blood counts, liver enzymes, hepatitis and HIV serology, IgG, and post-therapy also, the blood count, serum IgG and the CD19 positive cells. So I will end my talk here. Take home message: the choice of steroid-sparing agent is decided by multiple factors like age, whether the child is having a frequently relapsing or a steroid-dependent course, what is the steroid threshold, whether the child is having steroid toxicity, complicated relapses, the comparative efficacy and also the side effect profile of the steroid-sparing agents, the cost, and last but not the least, the parent's preference. It is very important that you monitor for the side effects with or without therapeutic drug level monitoring wherever indicated. Recommendations are evolving as more and more studies are coming up, so it is very important that you keep yourself updated with the latest guidelines. And I would also take this opportunity to invite you all for the third ISN SRC nephogenetics update, which is part of our ICH pediatric nephrology annual update. It is going to be held in Kolkata on 24th and 26th October. The first day will focus only on nephogenetics and the second day will be focusing on API. We have great scientific program. So I would really love to have you all in that program. Thank you.
Thank you, Dr. Devilina. Now the time is running, so question and answer will be at lunch. Thank you.
Thank you.
Thank you, Doctor. I will request all the chairperson and the speaker to please come for the memento distribution. Dr. Devilina.
Dr. James, please come.
Moving on next, we have another talk, and for chairing that session, I will request Dr. Professor Hemant Kumar Sir, Professor Pediatrics, Patna Medical College Hospital, and in charge of pediatric nephrology OPD clinics, has a keen interest in pediatric nephrology. I will request Sir to please come on the dais. Dr. Hemant Kumar Sir. Dr. Deepak Kumar Sir. Sir is the head of nephrology at Vedanta Hospital. Deepak Sir. And Dr. Rakesh Kumar Sharma, sir is the Assistant Professor PMCH, PICU in charge, and EB member from Central IAP from Bihar. I welcome you, sir. Dr. Sakil, I will request Dr. Sakil to please come on the dais.
Thank you once again, Dr. Gopal sir and all his team for the wonderful academic event. This was a topic on complications of nephrotic syndrome, and this was supposed to be Dr. Mridu Plavan Gover's topic, but then in the last moment he couldn't make it, so I'm just trying to fill in his gap. So can we have the slide please?
Thank you, organizers, for giving me the opportunity to share this important session. The speaker is Dr. Sakil Akhtar. He is Associate Professor in the Department of Pediatric Nephrology, ICS Kolkata, and has keen interest in UTI and nephrotic syndrome. He has a number of publications and he is Secretary of APNEICON. I would like to request you to start.
Thank you for your kind introductions. I think half of my work is done by Dr. Himesh, who has been extensively discussing a few of my slides, and also Dr. Devilina has been kind to discuss some of the things that I want to complete here. So just to begin with, nephrotic syndrome, as you know, is one of the most common glomerular diseases that affects children, and most patients generally do not develop complications, but if you have children who are in a long-term steroids, who are complicated course, having severe proteinuria, steroid-dependent ones, the steroid-resistant ones, and the ones who have been receiving long-term steroid as well as immunosuppressants, these are the children who develop complications very often. So if you have children who have non-minimal change disease and biopsy showing FSGS or evidence kind of, so they have a prolonged proteinuria having set a higher risk of complications. Now when we talk about complications, we mean the complications per se from the disease itself, And also there will be complications because of the long-term steroids and also the various cytotoxic agents and immunosuppressants that we use in these children. Now coming to disease-related complications, we have the most common being the infections, followed by hypovolemia, hypovolemic shocks and crisis, thromboembolic and thrombotic manifestations, some cardiovascular complications, acute kidney injuries, anemia, and some hormonal issues, and also defects in minerals and electrolyte imbalances that we see. Now again, talking about drug-related complications, I think Devina has covered everything in detail, so we don't need to discuss this. Now coming to the most important complications, as I said, infections being the most common in these children, because these children often require multiple courses of prolonged steroids. Apart from that, they are also receiving second-line immunosuppressants, which causes depressive immunity. So if you talk about the causes of death, infections remains the #1 causes of death in our kind of children, especially in developing countries like ours. Now, among the most common offending agents, Streptococcus pneumoniae remains a very common offending agent, mainly causing bacterial peritonitis. And apart from that, there are also beta hemolytic streptococci, Haemophilus influenza, gram-negative bacteria like E. coli, Klebsiella. They are very frequently associated with infections. Apart from bacterial infections, there are also viruses which are causing a lot of problems like influenza, even COVID times. We have seen coronavirus positivity. We have seen varicella quite commonly in children who are on prolonged steroids. And the reason for having these complications are because of the depressed immunity. This is in turn because of the low serum immunoglobulin G and other factors like factor B, factor I, and there are also depressed T cell functions and also dilution of the humoral defenses because of the edema. This may play a role in causing susceptibility of nephrotic children to infections. Now just to begin with, one very prototype case that we often get, like this is a child, a 6-year-old, steroid-dependent child in relapse, having steroids and also in MMF for a long time. The child attended the ER with pain, abdomen, fever, vomiting the last evening. The child is edematous, having ascites. The child looks febrile, sick, and dehydrated. On examinations of the abdomen, the child had diffuse tenderness, and the child was in relapse, so had a proteinuria of 3+. And initial investigation showing very high counts of 23,000, neutrophilic predominance, and the CRP was high. So what do you think a diagnosis could be? If you have close visit, you can just tell the answer, or it's likely to have? Any guess? So it's a typical case of bacterial peritonitis. So if you look at the guidelines here, one of the most common infections that we come across is bacterial peritonitis, and the offending agents most likely is to have Streptococcus pneumoniae, and followed by Streptococcus pyogenes, E. coli, and other gram-negative bacteria are also found. So all the investigations, baseline investigations, and also the peritoneal tap, if you are able to do it, always do it. Send the fluid for the cultures and also the counts and cell type. So if you have acidic fluid more than 100 WBC per millimeter cube, having predominantly neutrophilic, and if your cultures are not showing the offending agents, it's important that you treat aggressively these children with antibiotics. Meanwhile, you can start, after setting all the cultures and other basic investigations, you can start with injections like ceftriaxone or cefotaxime, and to begin with, and then wait for the culture report. So this is another child, a girl who's a FRNS child, steroid dependent, again on steroid and MMF in relapse, having a pain in the eyes, and there was swelling and redness that developed in the left eye. So this child having a left eyelid redness and edema, tenderness, and the child having proteinuria of 3+. So it's likely to have cellulitis. So we can find cellulitis in these children, can be cellulitis over the thigh, in the abdominal wall, parietes that we mostly find. And the cellulitis offending agents again, Streptococcus aureus, Staphylococcus aureus, Streptococcus H. influenza are commonly seen. It's important that you be very careful about these cellulitis. It can be preseptal, it can be septal. The moment you detect septal, they are more toxic, they are likely to have intracranial extensions, can cause meningitis also. So that's important that you pick it up. If you're suspecting septal, always do an MRI of the orbit. So just to rule out whether the child is having intracranial complications. And it's important that you start in the early treatment with Coemaxclav, Cloftlane, and ceftriaxone. Now we've had this cell, I think Shubhankar is there. We had two children who presented with known case of nephrotic syndrome for a long time. suddenly came after diarrhea with vomiting and severe headaches. We were not able to figure it out what is happening. So we did an MRI and followed by MR venography, and what we found was the venous thrombosis. So these children of nephrotic can present with cerebral sinovenous thrombosis. There are times we have also seen renal venous thrombosis in children. So these are not very uncommon, and the reason for this is that these children have the tendency to be in a thrombotic state. So there are disturbances between prothrombotic component which increases and antithrombotic component which will be lowered. So there is an activation of component like increase in synthesis of factors 5, 7, 8, 10 and 1 million factors, and also fibrinogen. And there will be decrease in amount of anticoagulants. So those are antithrombotic 3, protein C and S, which basically represses the anticoagulations. Apart from that, there are also changes in glomerular hemostatic mechanism, depressed intravascular volume state, and also exposure to steroids, and also non-judiciously if you are using diuretics that can cause this. Now, there was another child of FRNS, SDONS, again receiving long-term steroids and admitted with vomiting, diarrhea, abdominal pain, and the child was in relapse. So you have a child with ascites, abdomen, but it's not tender, the child is not very sick looking, but passed less urine. He had poor extremity tachycardia, and if you look at the initial blood report, the CRP was normal, and it looked like the hemoconcentration was there. So this child presented with hypovolemia. So the risk of hypovolemia is because of the severe depressed albumin levels and high dose of diuretics probably we are using without assessing the volume status. That is very important. Especially when you have a child coming with diarrhea, loose stool, looks hypovolemic, then this is something that you need to address aggressively. So these are some of the features that you look for if you are having a child like this. There are certain clinical parameters like abdominal pain, vomiting, and you have a prolonged CRT, tachycardia, and low BP sometimes will be there. And you also have to look for biochemical parameters like elevated hematocrit level. Always look for PENA, because that's normally what we do initially. So fractional excision of sodium is less than 0.5 points towards the hypovolemia. And then sometimes we check urinary potassium index. If it is more than 0.6, again that points towards the hypovolemic shock. So nowadays we also have in our own board we have ultrasound wherein our intensivists or our pediatric nephrologists, they are able to check the IVC status. So if your IVC status showing that it's less in diameter, or if the collapsibility index is more than 50%, that is an indicator that it's a case of hypovolemic shock. So if you are assessing the euvolemic status, always do all three of these parameters and then reconfirm without before giving IV fluid or boluses or albumin. Now sometimes you also have in prolonged cases cardiovascular complications, and these are because of the hyperlipidemia. So if you look at most of these children of nephrotic syndrome, they are likely to have higher cholesterol and higher triglyceride level. They may be elevated VLDL and LDL. Now these cholesterols or these lipid profile derangement can cause vascular damage. They can cause damage to the glomerulus, to the interstitium, and the endothelium also. This leads to sclerosis, and there will be evidences of premature atherosclerosis and also coronary artery disease. Now, edema may be a presentation of nephrotic, as we have seen, but it can also be challenging many of the times, especially those who are severely immunocompromised, receiving long-term steroids, the bad ones, the steroid-dependent ones. Many of the time they come with severely edematous, and then managing those edema can be sometimes very challenging, as we have seen. So the main cause of edema is there are a lot of theories like capillary refilling theory. So those things are there. So basically the basic cause is because of the increased glomerular permeability, and this leads to hypoalbuminemia. This in turn causes decrease in plasma onboarding pressure. So there may also be ascites and pleural effusion that we see sometimes, but we do not see pericardial effusions too commonly unless the child has some cardiac compromise. Sometimes we also see anemia. This can be anemia of iron deficiency type, like microcytic hypothalamic chronic anemia, typical like any other iron deficiency, but they may not respond to iron properly because of the fact that there is a loss of serum transferrin through the urine when there is a child is having proteinuria. There can also be urinary loss of erythropoietin along with the transferrin also. So these leads to even erythropoietin deficiency. So sometimes therapy with iron and also erythropoietin may be needed in rare circumstances. AKI may not be so common in most of the nephrotics, but yes, If it is there, they come with very guarding complications, and they come with very serious complications of nephrotic syndrome, and that needs to be aggressively treated. And these AKI can be precipitated by hypovolemia or hypovolemic shocks, can be because of the nephrotoxic drugs, radio contrast agents sometimes used, and also can be because of the NSAIDs. So most of the children who are massively proteinuric, who are having a low albumin, they already are in a low circulating volume in the plasma. We are likely to have circulatory collapse leading to renal. In that, if you have child who is receiving NSAIDs or nephrotoxic antibiotics, or if the child is receiving AC inhibitors kind of drugs, then they are likely to go into AKI. So because of the severe proteinuria, there is a tendency to have a low glomerular filtration rate. In that, if you have these drugs and all these precipitating agents, offending agents associated, they are likely to go into AKI. So aggressively treatment, and initially you just pick it up earlier and treat early and aggressively, that is a thing that should be aimed for. There are times if the child does not respond, then you might need even hemodialysis or other means of dialysis. There are some hormonal issues that are normally seen. While thyroid function test normally is in the normal range in most of the nephrotic, but there are times we have seen because of the proteinuria, there are losses of C3 and also thyroid binding globulin. This may lead to the low level of C3, T4 and DDG, so that causes basically hypothyroidism that needs to be treated sometimes. Especially the younger ones needs to be treated sometimes. Hypocalcemia is because of the decreased albumin level. This is because of the fact that the albumin is bound to the calcium is bound to the albumin level. So we have also seen abnormalities of vitamin D, and very rarely we have seen, I have not seen actually, but theoretically there may be a susceptibility to interceptions as well. Now there are drug-related complications, a huge number of drugs that we have discussed just now. I'm not going to repeat this, but then a lot of these children has complications because of the various drugs we use. The most common being the steroids, because a lot of complications arise from the steroid itself. But then when we are using other drugs apart from the steroid, they just add up to the adverse effects that we have seen. So to conclude, complications in nephrotic syndrome can be due to the disease per se, and also because of the drugs also. So early identification and appropriate treatment for acute complications is very important, and we need to have regular examinations and proper monitoring of these children for chronic complications, and this will improve the outcomes of children with nephrotic syndrome. Thank you very much.
Thank you for enlightening. It's a very common aspect of the nephrotic syndrome, but most of the attendants report in the complications develop.
Right.
Either with abdominal pain or intoxication. I have a very simple query. The patient of nephrotic syndrome is already on steroid. He develops infection. What about the steroid? Previously we used to stress steroid therapy in infection.
Right.
What is your view? Second question. What is when it is the time for starting statins in nephrotic syndrome, when it is the time for starting growth hormone in nephrotic syndrome?
Okay, so first thing, your first question is on steroid. So if any child of nephrotic syndrome, even if the child is in relapse, having infections, we have to give steroids, because steroid is, when you are using prednisolone, 0.6 to 0.8 milligram up to 1 milligram per kg per day. We give steroids during any kind of infection, because that is also called kind of stress to the body. Not only during infection, even during the peri-operative period, we put the child on steroids. These steroids are given just to basically combat the infective period, which causes extra stress to the body. We give it for 5 to 7 days, during which we try to treat the infections. Once the infection is over, we try to, if the child is in relapse, we will put the child on full dose steroids after treating infection.
We switch to prednisolone or
depending on how the child is. If the child is very sick, very severe, we do not give orally, we switch to methylprednisolone. Or we give hydrocortisone. Hydrocortisone 100 milligram per meter square, and we give it in divided doses of 3 to 4 times. Right. So regarding statins, there are controversial issues. I think ideally we do not start statins in children. And because the role is very dubious, so most of the studies do not tell the children should be started on statins. So I think statins should not be used in children. So there are no reports saying the utility of statins in children.
Decisions regarding growth hormones, soon after controlling all the things, the steroid, sparing agent, all the things, the child is growth retardation. Because most of the time, parents are unattentive of that. The growth retardation of child. Any aspect of your experience of growth hormone is
Growth hormone, I think prolonged steroids and the ones who have a very complicated course, they tend to be having short stature. I think first we also see whether nutritionally how the child is. So I think attending nutrition first would be very important. But prolonged steroid can cause short stature. But I think Dr. Raji would be very kind enough to share his experience because in my experience, have not used too much of growth hormone in from children. But yes, in CKD we have used because they have been.
Yes. They have gone to the steroid sparing agent. Even if that after that the child is growth retarded, then can we switch on to growth hormone therapy or any indication of your association for the growth therapy?
Yeah, so if I can answer that,
we have used, but for nephrotic we have not had children. If Dr. Radhika has more experience in this.
So the number one thing is that you have to stop steroid. After stopping steroid, you give some time for the child to grow. If the child is not catching up, then you can use growth hormone. But growth hormone is expensive, and we always feel that the nutrition and other things are important. But after stopping steroid, I have referred 3 children to the endocrinologist for growth hormone while on steroid, and they have said that growth hormone will find it difficult to work if the child is on steroid. Answering your starting questions, again they are primarily for steroid resistant nephrotic syndrome above 10 years. Below 10 years at the moment evidence is not strong.
Thank you. Actually, I would like to add one question to this question that very frequently we get cases of complicated relapse in our hospitals. And complicated relapse maybe because of simple bacterial infection or maybe because of some tuberculosis infection. In that case, how to approach, how to treat that child? If the child comes with complicated relapse with bacterial infection or complicated relapse with tuberculosis infection. Should we start antibiotics steroid together?
For infection, you're saying?
Yes.
So many of these children, as I said, comes with infection, and infection is very common in our kind of country because of the hygiene issues, also because of the vaccination coverage, which is low. So first and foremost, you have to aggressively treat infection because these children are so immunocompromised. Their infection tends to be very florid, very life-threatening also, many of the times. So first, if the child is already receiving immunosuppressant, we stop the immunosuppressant for a while. If the child is on steroid, we try to give scarce dose steroid just to combat the body stress. And then we try to aggressively find out what the infection is. Most commonly what we get is maybe bacterial peritonitis, we get pneumonias, we get viral infections also. So we try to aggressively treat those infections first. Once you are able to handle the infections, I think the child will come out of it. And then we again restart your protocol of therapy, whatever you're giving. And you try to review what the child has been receiving over the last maybe since the beginning. If the child is properly treated or not, if the child is coming for regular follow-up or not, and what immunosuppressants is the child coming with. If the child is particularly not being treated properly, so that has to be regularized. The child, family has to be counseled. And suppose we are using immunosuppressant and then the child continues to have relapses and complicated relapse, it's time that you move on to the next level of drugs what you're using. Right?
It is the same for tuberculosis also.
For tuberculosis, so tuberculosis is a child of nephrotic coming with tuberculosis. I think you first detect, you have to first confirm the diagnosis of tuberculosis. We do Martin test, we do the X-rays.
It is a confirmed tuberculosis.
What?
It is a confirmed case of tuberculosis.
Confirmed tuberculosis, I think ATD should be started once and for all. Nephrotic takes the second hand. First, tuberculosis is a priority in our country. And then tuberculosis infection, we don't give full dose steroid. Even if the child is in relapse, even if the child is in active nephrotic syndrome. But then what we do is that, suppose the first time diagnosed tuberculosis with nephrotic, I think you first start with ATD, continue for maybe 4 weeks, and then
अच्छे से नहीं आया
एक्चुअली में आपको बोलते हैं ना तो वो माउथ बोलना रहता है ना तो इसलिए मैं आपको
Thank you.